So today I will be discussing about the facial nerve. When you see the ferocious tiger there, what makes the tiger so ferocious? It's probably for me, it's the movement of the facial muscles more than the body or the expression of the eyes. It's the movement of the muscles that makes the tiger looks so ferocious. So facial nerve has an important role in expressions. That's what I want to convey. So what's the pathway of the facial nerve? It exits at the cerebellopontine angle after taking origin in the pons. The nucleus is in the pons. It divides into five branches, supplying different areas of the face. This is a very common question. The branching happens in the parotid gland, and the five branches are the temporal, zygomatic, buccal, marginal mandibular, and the cervical. So this is the nucleus depiction of the fifth, sixth, and seventh nerve nucleus. You can see the facial nerve looping around the nucleus of the sixth nerve. So that is a common question in the exam. So after entering through the entering the skull through the internal meatus, you can see it continuing as chorda tympani to the sublingual and the submaxillary salivary glands. A branch goes to the lacrimal glands also. So facial nerve is a sort of a it's an all-rounder. It has multiple functions. That's the beauty of the facial nerve. So what are the functions of the facial nerve? Motor, the functions as I showed the tiger, the muscles of facial expressions, the stapedius in the inner ear, posterior digastric, stylohyoid, and the platysma. Sensation from the anterior two-thirds of the tongue is carried by the facial nerve. Parasympathetic supply to the submandibular and sublingual salivary glands and to the lacrimal gland is by the facial nerve. So the clinical features, what are the clinical features which we obviously know very well? There is loss of forehead wrinkling, loss of furrowing, the brow drops, that is brotosis. It's not ptosis of the eyelids, brotosis. Incomplete eyelid closure, drooping of the mouth with possible drooling, deviation of the angle of the mouth to the opposite side. There can be associated pain around the jaw or behind the ear. There are headaches. There are changes in the taste, tearing, hearing. So it can have protean manifestations. What we see in the exams and what we commonly know is there's a deviation of the angle of the mouth, but it has protean manifestations. So there are certain ocular signs of facial nerve palsy also, such as upper eyelid retraction, lower eyelid paralytic ectropion, and laxity with widening of the palpebral fissure. There is lagophthalmos, there is incomplete blink, and the exposed cornea can develop keratopathy. So what you should look at is you should see the symmetry of the face in inspection sort of. When you inspect the face, if there is a bilateral weakness, the weakness in the forehead and the lower face is almost the same. So it is a bilateral lower motor neuron facial palsy. So bilateral weakness where the forehead the upper part of the face has relatively preserved strength as compared to the lower face. It's a bilateral UMN palsy. Why is it so? We'll discuss in detail later. Normal strength, but there is no spontaneous movement. So for voluntary commands there is movement, but if you crack a joke or if there is some emotional stimulus, there is no expressions on the face. So as you know, that expressionless face of Parkinsonism, that is emotional paralysis. So I have given a few causes of bilateral element palsy, sarcoidosis, and Guillain-Barré syndrome. Bilateral upper motor neuron palsy is seen in pseudobulbar palsy, and motor neuron disease. So next is when the face is asymmetrical. So if the forehead strength is relatively preserved as compared to the lower part of the face, it is unilateral UMN. Why is it so? Again, we'll discuss. If the forehead weakness is equivalent to the weakness in the lower part of the face, it is unilateral lower motor neuron lesion. The face is asymmetrical, but there is no weakness on testing, so it's probably congenital. Again, I have given you a few causes of UMN and LMN unilateral lesion. So unilateral UMN is due to cerebrovascular accidents, what we commonly see in the exams with stroke and UMN facial palsy on the same side, demyelination and tumors. Unilateral LMN, Bell's palsy, pontine vascular accidents. Here it is a crossed hemiplegia. So the hemiplegia is on one side and the LMN facial palsy is on the other side. Ramsay-Hunt syndrome, Lyme disease, and basal meningitis. So this is a depiction of LMN and UMN facial palsy. So what you can see here is this is the LMN type. So eyes does not close, the eyeballs roll up. This is again a very important question, what is known as the Bell's phenomenon. There is a flat nasolabial fold. It is almost not visible. And when you ask the patient to raise the eyebrows, there is no wrinkling of the forehead. There is no raising of the eyebrows. That's what I said, eyebrow-ptosis. There is no raising of the eyebrow, and the lower part of the face is paralyzed. So this is the total involvement of the face. Total one side of the face is involved. That is typical of a LMN lesion. So what you see in a upper motor neuron type of weakness. So here the eye closes perhaps with a slight weakness. So the patient is able to close the eyes. There is a grading which we'll be describing later. Again, the nasolabial fold is flattened. And if you ask the patient to raise the eyebrows, the forehead is wrinkled. Probably he can furrow also. But the lower part of the face is paralyzed. So what you can see is the upper part is relatively spared. So this is typical of a UMN lesion, and you can see the deviation of the angle of the mouth to the opposite side. So this is the difference between UMN and LMN facial palsy. So this is one word I found catchy: face, ear, taste, tear. That summarizes the facial nerve. So look at the symmetry of the face. Watch for spontaneous movements. This we generally don't do. When you crack a joke or if there is some emotional stimulus, that smiling, blinking that normally happens, that makes our life so cheerful and so dramatic, that doesn't happen with subcortical facial nerve involvement. And you give certain commands to the patient. You ask him to show you his teeth, you ask him to whistle, you ask him to close his eyes tightly, and you assess the strength by trying to open the eyes. You ask him to look up at the ceiling, that is to lift the eyebrows and for looking at the furrowing, and you compare the strength of the upper and lower part of the face, just a relative comparison, and you should always observe for Bell's phenomenon. So what else should you see while examining the facial nerve? You should look at the external auditory meatus, because it can give clue as to the cause of facial nerve involvement. So presence of vesicles suggests herpes zoster, what we call as Ramsay-Hunt syndrome. Testing which is generally not done because of the tediousness. So you to genuinely test taste, you should have a saline solution, sugar solution, bitter solution, sour solution. So very difficult to arrange. At least you can have saline and sugar solutions. So a cotton bud is dipped and applied to the tongue, and the patient is asked to identify. Obviously, the patient should be closing his eyes. You dip a cotton bud in saline solution and sugar solution and test various parts of the tongue on each side of the anterior 2/3 and posterior one-third. In facial nerve involvement, there is involvement of the anterior two-thirds of the tongue. So why is upper part of the face spared? This is a very common question in the exams in upper motor neuron lesion. So as you can see from the cortex, there are two inputs to the facial nucleus from both sides of the cortex, right and left, to the nucleus, which supply the upper part of the face. So the pink is the upper part of the face. As you track the pink fibers to the nucleus, and you can see there is bilateral representation. So the nucleus, facial nucleus, is supplied from both sides of the cortex. Whereas if you track the green one, which supplies the lower part of the face, so there is only unilateral representation. You don't see the green here. So there is unilateral representation. So obviously when there is a supranuclear lesion, the upper part of the face is spared because of bilateral innervation of the bilateral inputs from both sides of the cortex to the facial nucleus. This is a very important concept and is frequently asked in the exams. So there is a entity known as the visual smile sign. This is to bring out the dissociation between the voluntary and the emotional aspect of the facial muscles. So failure of the patient to smile when asked to whistle in patients with emotional paralysis due to Parkinsonism is called as visual smile sign. So voluntarily probably he may be able to move his facial muscles, but if you crack a joke or give some emotional stimulus, there is a paralysis. So this is a diagram from NEJM which I had taken. So when you give the orders, that is, show me your teeth. So what you can see is this is the eyebrows are lifted. You can see the furrows here, and the lower part of the face is involved, but there is relative sparing of the upper part of the face. Here there is no furrowing of the forehead. There is no creases here, so the total face is involved. So this is a lower motor neuron type of weakness, and this is a upper motor neuron type of weakness where there is relative sparing of the upper part of the face. This is facial spasm, which you don't have to focus too much, which happens when there is a irritative focus. So the facial muscles go to spasm. So you have to concentrate on the UMN and the LMN lesion. In an UMN lesion, the upper part of the face is relatively involved, whereas in an LMN lesion, because it is the final common pathway, the whole of the face is involved. So this is to bring out the emotional and the voluntary dissociation that can happen with facial nerve palsy. So this is the CT scan of the brain where you can see cortical infarcts. These white areas are the cortical infarcts. So when there is a cortical infarct, what happens is when you give the command show me your teeth, so what happens is there is paralysis of the face, and there you can see the obvious deviation of the angle of the mouth. Whereas when you crack a joke, what would you do if you found a horse in your bathtub? So I don't know how many people will find it as a joke, but that's the example given in NEJM. You can see the response is almost normal. So the emotional aspect is preserved, whereas the voluntary aspect is lost. This is indicative of a cortical lesion. So this is again, you can see these are the deep-seated structures. There is a infarct there. So all the nuclei, deep-seated nuclei are here, and they cause the extrapyramidal symptoms, the prototype of which is Parkinsonism. So when you give a voluntary command such as show me your teeth, the paralysis is less obvious. If you see the angles of the mouth or the nasolabial folds, the paralysis is less obvious. Whereas with the joke, with the emotional stimulus, what would you do if you found a horse in your bathtub? The paralysis becomes more obvious. You can see the deviation of the angle of the mouth and the widening of the palpable fissure. You can see the eyes more prominently. So there is the paralysis is more obvious here with the emotional stimulus, and the location of the lesion is in the deep-seated nuclei. So this is an attempt to just see the causes of facial nerve involvement, which is very common in the exams. What are the causes of element type of facial palsy? What are the common of causes of human type of facial palsy? So element type of facial palsy you can get in Lyme's disease, which is due to a spirochete, Borrelia burgdorferi. There is history of tick exposure, rash, arthralgias, and in endemic areas. It's not very common in India. In otitis media, again you can get element type of facial palsy where the bacterial pathogens, the gradual onset, the CSOM, ear pain, fear, conductive hearing loss. Ramsay-Hunt syndrome, which I briefly told about earlier, is due to herpes zoster virus. So there is pronounced prodrome of pain, and the clue to that etiology is the vesicles in the ear canal or pharynx. In sarcoidosis or Guillain-Barré syndrome, it's element lesion due to autoimmune cause. It's more often bilateral. Tumor, parotid tumor, cholesteatoma, the onset is gradual. That's very typical. In supranuclear lesions, the central lesions, multiple sclerosis, it's usually due to demyelination. You have additional neurological symptoms like optic neuritis. It has multiple areas of involvement. Stroke is what you normally see in the exams. So ischemia and hemorrhage, and you get ipsilateral hemiplegia with human facial involvement. If you get crossed hemiplegia, the lesion is in the brainstem. But if you get the ipsilateral hemiplegia with human facial involvement, it is in the it's above the brainstem. So this is a very important point. Again, tumor, either a metastasis or a primary brain tumor, can cause gradual onset facial nerve palsy with mental status changes, and there is also a history of cancer. So this is something new which we are not read in our times, the grading of the facial palsy. I found this quite easy to remember among the various interpretations of the grading. So this is House-Brackman grading of facial palsy based on the ophthalmic signs. So grade 1 is normal blink and eyelid closure. So it's almost like normal. Grade 2 is full eyelid closure with minimal effort. The eye closing is important. Eye closing and facial symmetry are the two important things in the grading. So full eyelid closure with minimal effort is grade 2. Full eyelid closure with maximal effort is grade 3. In grade 4, what happens is there is incomplete closure, but the facial symmetry is maintained. In grade 5 is the worst case with incomplete closure and facial asymmetry. And grade 6, there is no eyelid movement at all. So this is the grading of facial nerve palsy. So this is in brief about the facial nerve palsy. It's obviously not a replacement